Some doctors, some that we even respect, they acknowledge, yes, absolutely, people are losing a lot of weight with these, but they are losing a lot of lean muscle mass as well. That sounds really bad. I don't want to lose any muscle mass. What's going on there? Is that a legitimate issue? This is Generation Health. Every week we bring you the latest in news, cutting-edge research, and time-tested best practices, helping you live a longer, better life. To my right, Dante DiMatteo, PharmD, certified strength and conditioning specialist. Hello.
Hello.
And across from me, Joey DiMatteo, PharmD, board certified clinical nutritionist. How are you, my friend?
Very good, Tyler. How are you?
I'm good. Back behind the console, mic number 4, Josiah Schweinberg. Hello.
Hello, my friend. Hello.
I expect a musical intro every time now.
Good too. All right, that's enough.
Thank you.
That was beautiful, dude.
My name is Tyler Andrews. Dante, what are we talking about today?
We're going to talk more about GLP-1s, except a little more about the hype and the controversy associated.
Yeah, a little less technical, a little more esoteric.
That's right.
That's my $5 word for the day.
That was beautiful.
Thank you. Thank you. All right.
I'm Googling it.
Once again, because we are not, because everything we're going to talk about today is newsworthy, we're just going to skip the news segment and dive straight in. So last episode, we talked all about obesity and GLP-1 agonists. There's another term for it. What was it? Mimicry? No, it wasn't a mimic.
Incretin mimetics.
That's the one. So fancy. See, I've already forgotten. But we talked about all the technical stuff last time. This time, we're going to talk about controversy and the fun stuff that's in the news. There's still a ton of conflicting headlines every single day. We want to seriously look at and try to analyze what's actually happening, what's actually going on, and see if there's anything really being reported worthwhile or if it's all just nonsense. So, diving straight in. This one comes from the UK's Daily Mail. The headline, this is amazing. Woman will suffer diarrhea forever after Ozempic caused horror bowel injury, and weight loss drug made another vomit until her teeth fell out, claims dozens of lawsuits saying maker failed to warn of its dangers. In the article itself, it says, in one case, a woman who used Ozempic and Mounjaro claims she was diagnosed with gastroparesis, which caused her to vomit so much that some of her teeth fell out. In another, a woman was diagnosed with a life-threatening bowel injury, unquote, after using Ozempic and underwent surgery, which lasted nearly 9 hours. Doctors said she would be in pain for the rest of her life and, quote, will never have a solid bowel movement again, unquote. A third case in this set of lawsuits, a third case brought by a woman who used Wegovy, claims she was diagnosed with, quote, severe gastroparesis, unquote, and was hospitalized with symptoms including going a week without a bowel movement. What is going on? Those are some pretty insane headlines and side effects. Is this a normal thing? What is going on? Can you give me some explanation? What is gastroparesis and what are they talking about here?
Yeah, so like we discussed in the first episode, one of the benefits of the GLP-1 receptor agonist is the ability of the medication to help slow gastric emptying. And now gastroparesis is essentially taking that one step further where there is a more marked delay or essentially stopping of gastric flow in the GI tract.
So it's just gone
way down.
It's turned it up to 11, so to speak, and not emptying properly at all.
Right. And so clinically, what they'll see is that gastroparesis is more or less confirmed when more than 10% of the standardized meal that they use in the test is still remains in the stomach after 4 hours.
Wow.
And so that's a pretty slowed transit time.
I was gonna say, food doesn't stay in your stomach anywhere near that long. It's supposed to pass through fairly quickly.
Yeah. But again, it's just to highlight that, again, something that is a benefit of the medication is now, one step further, a potential downside.
Yeah, and people that have been diagnosed with gastroparesis, we know it's contraindicated to use any of these medications because you've already got, an idiopathic stopping or slowing of the GI tract and the gastric emptying. So to add a medication that's going to do that. So we know that. It's the other end that's a little more complicated. Could it cause it and could it sustain it?
Right. So it's entirely possible that these people or some of these people are some of the thousands of people using it might have gastroparesis and not realize it. And then they begin taking a drug and it becomes pronounced and very pathological.
It's certainly possible. Just as most cases of gastroparesis are idiopathic, so not a really strong established cause, but also there's a whole list of medications that can also cause it as well.
Oh, well, and such as?
So there are certain narcotic pain medications that can lead to it. Certain antidepressants like amitriptyline, calcium channel blockers. So essentially blood pressure medications like nifedipine and diltiazem. There's a whole list, even substances like nicotine. The THC in marijuana is also has the potential to lead to that. So we're not saying that we're not discounting what these individuals are experiencing, but gastroparesis is fairly it's a fairly prevalent issue aside from this.
Okay. When you list all those medications and all that, it sounds like theoretically your doctor or a pharmacist would catch that you're already on one of these things. You need to be very careful about that.
Potentially.
Okay.
Yeah. It's not always a perfect situation, but again, it's like we'll get into, especially if you're, if you kind of go outside of your standard medical practice to use these medications, or you find one on your own,
Right. Yeah. That's why you want to work with a professional who knows you. Mm-hmm. What are the normal GI issues to look out for? Again, we've kind of covered them in the last episode. If you haven't watched that last episode, you need to go watch that one so that this is part 2 functionally. What are the normal GI issues to look out for?
Major ones: nausea, constipation, diarrhea, abdominal pain. So a lot of different GI issues.
And so this is a legitimate risk.
Mm-hmm. Mm-hmm. Yeah. So again, there's definitely some confluence here between, there could be persistent diarrhea and what we do see as side effects of the medication.
How common are these issues for people taking them? I know you don't have, strictly speaking, percentages necessarily, but is this something that is very common, is occasional? How common is this?
I think the label of Ozempic, I think that you shared, says less than 5%.
Upwards of 5%. Yeah.
So nausea, vomiting.
And that was in the initial trial, I believe, that in which it was granted approval.
So it is, that's 1 in 20. So it's not a non-issue, it's a possibility.
Yeah, and even in a kind of a microcosm of all of this, just being in a pharmacy and knowing individuals that have taken it in the dose escalation process, we've definitely heard of some of these side effects. But on the flip side, we've also heard of the resolution of these side effects too,
given a little bit of time.
Mm-hmm.
So, and then my understanding is that that's part of the purpose of the titrating up dose, is to kind of find where that level is and then back off from that.
Yeah. And not to get too far ahead, but a lot of the issues can occur, especially as you're then escalating the dose. If somebody's weight loss maybe plateaus a little bit, then you're in a position of potentially going up in dose again and, maybe kickstarting some of that side effect process again, more or less.
Okay.
Not for everybody, but it's, a lot of it is dose dependent.
Is there anything else doctors can do or that you guys can do to help mitigate this risk?
There's not a ton. I think a lot of it has to, again, do with proper dose escalation, just knowing that the dosing is probably going to take some individualization. Just because your friend down the street ended up on X milligrams doesn't mean that that's necessarily going to be the answer for you. Just staying hydrated, I know, is a very strong recommendation, as a lot of the kidney issues, which I don't really think we talked about. There are some kidney issues that can arise from taking these medications, but more as a reflection of the dehydration, vomiting, or the dehydration as a result of the vomiting and not really being able to eat as much and all of that. So hydration plays a key role in mitigating some of that in the short term.
So the big thing is just pay attention to it. Don't just ignore it, which that would be hard to ignore some of those side effects. Okay.
Yeah. And a lot of physicians seem to recommend, and a lot of this decision-making happens kind of spontaneously. that's a good word, I think, for this. A lot of the spontaneous reduction in weight loss as a result of, the essentially the loss or decrease of appetite is huge, but a lot of times they'll recommend individuals to decrease the volume of their meals as they get used to this new medication. So that can, I don't know how evidence-based that is, but I think that's a logical place to think, but again, a lot of people are even in the early stages are shrinking the size of their meals already.
Yeah. Cause they're just not hungry.
They're just not as hungry. Yeah.
Okay. All right. So all that is to say, this article is not completely out to lunch. These are legitimate issues potentially. As to the veracity of the lawsuit, we're not commenting on that, of course. But these are not completely isolated incidents. It is just something to be aware of and take into account. Here's another one.
You know what? Actually, real quick, and the last thing with gastroparesis was that it's very prevalent in diabetics as well.
Okay.
And so again, to backpedal to our first episode, the whole first part of the episode, we talked about the sort of the influence of diabetes on the formulation of these medications. And so there's a lot of type 2 diabetics, or maybe those who are pre-diabetic, even, who start taking these, and there's was it the medication? Is it the potential disease state? Is it both?
Right.
Or am I full of crap? You know what I mean?
Yeah,
There's certainly a,
or
no.
this article says the most common cause of gastroparesis is diabetes, and specific to this case, this woman was prescribed the drug to control her fluctuating weight and pre-diabetes.
Yeah.
Required 5 hospital visits before she was officially diagnosed with.
Wow. So they didn't catch it for a long time either.
Yeah, well,
sounds like.
They say gastroparesis is a lot of delayed
emptying.
No, it's delayed in diagnosis for some reason.
Fair enough.
Yeah, because I'm sure it's something that you will. Oh, my stomach just hurts a little bit.
Yeah,
I'm used to this. But meanwhile, there's sometimes a large, clump of food product developing.
Yeah, and if there's, there's warnings of these side effects to begin with anyway, that's like, oh, I was warned about some of these, but then they continue on for weeks.
Right.
Yeah, that can be very, very dangerous.
Yeah, you're right. Good point. Very hard to distinguish.
Yeah, and with the process of gastroparesis developing, then like Dante said, the process of figuring out what it is, now you throw in a medication, sometimes things just come together. And it doesn't mean that the Ozempic or whatever GLP had nothing to do with it. It just there's a confluence of things.
Yeah.
Mm-hmm.
Mother of 3 trying to banish belly fat almost died after a skinny jab, quote unquote, she bought online triggered organ failure. A mother of 3 has told how she nearly died after injecting herself with a, quote, skinny jab, unquote, that she bought online. Lindsay McAvoy from Edinburgh, Scotland, purchased the jabs on the internet in the hope of shedding belly fat, despite weighing just 112 pounds. After shedding around 7 pounds in just a few weeks, the mother of 3 ordered another batch of the injections. However, the 42-year-old beautician then suffered a severe allergic reaction, which saw her tongue swell up and her eyes burn, causing her to pass out. After being rushed to the hospital, medics informed her that she had suffered a severe allergic reaction to the injections, which can trigger organ failure. The severe allergic reaction can trigger organ failure in severe cases. She said she feels, quote, ashamed, unquote, and warned that despite seeming like a quick fix, the pens are dangerous. Okay, the first big question I have to ask is, what was she injecting? It says skinny jab. It doesn't say the drug name here.
Yeah, there's a lot of layers to this one.
Yeah.
I guess the first layer I'll take is that she got it online without a prescription.
Yeah.
We are a compounding pharmacy at our local place, so that's the last thing I want to do is bash compounding as a whole. But individual businesses, sometimes very small businesses, can make their own decisions about what they're doing with their compounding. And there's layers to this as well. But we are talking about something that she bought online without a prescription. $50, not a month, but I believe it was 50 euros per 2 weeks. Still very cheap to access this medication. We've even done some just initial looking into it, research into how much it would cost us to get it, just to be aware of what's out there. And that doesn't sound right either.
So whatever she was getting was not GLP-1.
Yes. And then partially, and again, I know there's a lot here, but this was an allergic reaction. So she could have gotten it from one place, or it was made one way. She could have had an allergy to one of the inactive ingredients, something that got contaminated. So with it being a compound injectable, bought online. So again, you keep lowering the bar maybe for what is accepted practice.
Yeah.
Mm-hmm. And now you throw in that it's an allergic reaction. It may have nothing to do with the actual semaglutide or the ingredient in there. It could have been one of these ancillary things that would be very hard to track in this situation.
Yeah.
Okay. So we don't know what she was injecting.
Yeah. The first one we're talking about is a side effect. Now we're talking about allergic reaction. So both of them I get are broadly issues associated with, but allergic reaction, very different here.
And the headline is clearly meant to pull you in thinking that's what it is, that this is the same thing. But she bought something online without knowing what it was, without a prescription. And yeah, the $50 or €50 that we already know. I mean, this is standard. We said it's like $1,000 a month or something like that.
And yes, that's, drug company prices, but still, even just at a compounding level, it's still very expensive. That's somebody making it in incredibly high volume, selling it online. This is again where there's multiple levels of ethics, let alone legality within compounding, that she found her way into. Maybe one with a little bit of a lower bar.
Yeah, it sounds that way. Now, you said compounding pharmacy. This is something that beyond just the brand name drugs, there are compounding pharmacies out there making something like this.
So this is another, we said this episode would have some controversy in it.
Yeah. Here we go.
The compounding of these products is very much controversial. The only reason that we see these being compounded at this point is because technically these commercially available medications are on the FDA shortage list. And so that leaves more or less some wiggle room for compounding pharmacies to step in and fill the gap until those products are removed from that list. So I think that's kind of, all we really have to say about it. I think to Joey's point, you just have to use an extra layer of caution when dealing with these compounding pharmacies who are just, no matter if it's this or any other sterile product, there's just a level of manufacturing, criteria that needs met.
Yeah.
So that would be step one, is just where is it coming from? And then also, obviously, there's just a general gray area of the specific form of the medication. There are certain salts that can and can't be manipulated, and there's a legality issue with that. And so I don't know. I more or less digress at this point, but it's everywhere. They're in med spas. You can get them directly. You can get them with a regular prescription. You can, get them through these, weight loss clinics, more or less. And so all we can really say is just try to use your best judgment.
Let me ask it another way. Would you buy a drug online and inject it without a prescription?
Yeah, thank you for centering us there, because this is again kind of like Joey said as well. This is totally different than doing some homework, talking to a doctor at a med spa, understanding maybe the background of a given compounding pharmacy who's certified to do this.
Right.
Exactly.
This is way different.
Way out in left field.
Certainly people could do whatever they want. People do all kinds of wild stuff.
They do.
And this is a wild choice.
We would not endorse this decision.
Yeah. So I think just to again make clear, we are not saying that all the compounded products are bad or inferior or a problem.
Right.
But there's a lot of layers to making sure. Again, I would view it as stepping in with your doctor's office. Do you trust this office? It seems like a reputable office, good reviews, research that. Then can you trust that they're compounding pharmacy that they would use?
Yeah.
Because technically they're only supposed to be making it for shortage purposes, which is still occurring. It's a gray thing.
Yeah.
It's a gray area. Is every time we go to order Ozempic, is it on shortage? No. But is it often on shortage? Yes.
Yeah.
So it is, and it has a place. The FDA shortage list has great value. We've made medications, anti-seizure medications for kids because the liquid's not available at times. So this has a purpose. This is definitely, it's just one of those things. People look for the loopholes, particularly when business and money is involved, and these are so hot right now.
Yeah. Mm-hmm. It's not in our list of articles here, but I know that I think Eli Lilly just bought 3 more manufacturing facilities to continue to increase Wegovy's availability because it's so in demand and shorted.
Yeah. I mean, and even in addition to the gastroparesis lawsuits, I mean, there are lawsuits with these big drug companies starting to single out some of the bigger players in the compounding space.
Wow.
So
I didn't know that.
so I guess to wrap it up, it is a bit of a legal mess.
Yeah.
It is. It's so you just kind of got to, at the consumer patient level, in addition to somebody in practice they just have to be careful with this stuff.
Yeah.
And not to pick on anybody, but the other thing that sticks out in this article to me is that she weighed 112 pounds when she decided to start taking a medication to lose weight.
Right.
People come in all sorts of different body types and different sizes, but that seems highly irrational to me.
Yeah. I'm glad that you brought that up because we know where these medications were studied. We know the context in which they were studied, and not that we're trying to sound like sticklers and we have all the answers, but we know based on what we talked about that these are indicated for specific BMI cut points in addition to the presence of certain comorbidities.
Right.
And so to extrapolate the information and the safety data from those studies and put them on to a person who is within normal weight or low body weight, for goodness sake, or whatever. It's as much as we want to be able to imply those same results or apply those results, it's you just technically can't. You have to be especially careful, and then the other aspect to that, with respect to our conversation on obesity in general, we talked about the fact that there exists a behavioral component, a psychological component, and a lot of times what you're dealing with individuals, regardless of their weight, is there history, or do they have histories of eating disorders or restrictive eating, certain patterns, or presence of other, mental health comorbidities, all of these things that are have an impact on how we eat, what we choose to eat. So it's just, I know she wasn't at that cut point in BMI, so to speak, but again, it just brings about that treating this condition and understanding this condition brings so much more than just the very black and white.
Yeah, we can't, obviously we're referencing an article and it talks about an individual. We don't know the person. We haven't seen her medical records, anything like that. But I think it's probably a safe bet to say that if she walked into a doctor weighing 112 pounds and said, I want to get this drug, that they would have said, no, no, you don't need
no
that.
amount of risk worth that, let alone.
Right.
Yeah.
Yeah, she even said she's quoted by saying that it was ridiculous. She was hoping to shed a few pounds, which she said was, quote, ridiculous because she didn't have any, quote, weight to lose.
Yeah.
However, she was unhappy with how her body looked.
Yeah. So these are not for everyone. How would we break down the categories of this whole thing? Those it's for, those it's not, and kind of a gray area. So who is it for? Again, we've hit this before, but we'll talk about it again.
Yeah. I mean, I think first and foremost, like the sub meta answer to that question is still, you're not walking into a doctor and they're demanding that if you have, an increased adiposity that you have to be on a GLP-1 receptor agonist. The biggest thing is, do you want to, you're still the driver of your care as far as health goes in general. So you have to want this. There's nobody is forcing this upon anybody, as much as it might seem like that at this point, just given how many articles like this exist.
The marketing and everything else.
Yes. It's everywhere.
Yeah.
It has a lot of benefit, but again, just that meta answer is that you have to first, want to do that.
Yeah.
You know what I mean? You have to want to lose weight. You have to buy in to the care that you're potentially going to receive.
So this is for people who want to lose weight, who are over the BMI cut points, have the medical conditions associated with obesity, for type 2 diabetics. Anybody else?
So there is one category that we have sort of left off, but to mention it would be pediatric patients. So it's indicated in pediatric patients age 12 years or older with an initial BMI at the 95th percentile or greater for their age and sex.
Okay. So Okay. So, but that's it. Those are the categories that it's specifically indicated for.
Right.
And that means that it's been tested on, that we know.
Yeah. You can
efficacy
more
and safety.
confidently. Yeah.
Okay. It seems like there's some people that it's totally inappropriate for. Who are we talking about there other than this one woman?
Yeah. So that question brings about almost like the cosmetic. Of course, there's a cosmetic component to weight loss, sure. But in general, it brings about the performance cosmetic side of things. That's just, kind of comes with the territory here. You're talking about weight loss, and body image is very much a priority for a lot of people.
Right.
Performance is very much a priority for a lot of people. And so you have people, influencers, certain people taking it out of the context that we just described, in that we discussed those that it's indicated for technically. And so again, you've kind of lumped it into this. I don't know if it's the best way to characterize it, but it's a cosmetic performance image crowd.
Yeah. They're not doing it for medical reasons.
Mm-hmm.
And then there's kind of a gray area there.
Mm-hmm.
How do I know who's in the gray area? What that we're saying maybe not.
I think ultimately there's still a conversation with your. That's the whole point of having a good relationship with your provider.
Yeah.
You might find yourself in the middle zone, fighting for insurance coverage just because your BMI is slightly outside of the range, but you've struggled with appetite. This is really a problem. You've been on the yo-yo dieting thing. You might be pre-hypertensive, that's how they used to call it, or maybe you're borderline pre-diabetes, and you're in what you would be considered a gray area.
Yeah.
The key is to have somebody that you can rely on for additional information. And then you come to a shared decision.
Yeah.
But then in general, who we can't really speak to is, because you can go online and buy these, you can find compounding pharmacies, you can find spas. Like I liken this to sort of although it's not a anabolic steroid, it's just that you liken it to the testosterone replacement optimization crowd.
Right.
You know what I mean? It's like we could talk about the gray all day long, but it's just crazy that even though these are two very different medications, TRT, testosterone injections, whatever, and these, glucagon-like peptides, it's giving off a similar feel.
Yeah.
Segment that there's an overlap for sure.
And this isn't the time or place for the conversation, but it's interesting to see the way that the commercialization of medicine has played a major role in the way people perceive it and go, oh, that must be me. That's definitely for me. I need that.
Exactly.
Okay. So there's that gray area. You mentioned the performance and the influencers and that celebrity culture surrounding things has gotten it a lot of attention. And in some sense, that's a good thing, because people that wouldn't have known about it are finding out about it and they actually can use it. But it's worth saying, hey, just because your favorite celebrity has talked about it doesn't mean that you need to be doing that, or even that they necessarily should have been doing that.
Mm-hmm.
So I know a lot of doctors, maybe not a lot of doctors, some that we even respect, I've seen where they are concerned with, they acknowledge, yes, absolutely, people are losing a lot of weight with these, but they are losing a lot of lean muscle mass as well. That sounds really bad. I don't want to lose any muscle mass. What's going on there? Is that a legitimate issue?
Yeah. So before, I think, if at all, getting into the specific studies that looked at maybe the effects on body composition, let's say, what you have to understand at the outset is that the magnitude of weight loss that's occurring when using these medications, so Wegovy or Mounjaro or any of them, you're talking 15%, 16%, 20, up to 26.5% of weight loss. The loss of lean tissue is more reflective of the sheer amount of weight that's coming off. It's like any weight loss. The weight loss secondary to using one of these medications isn't uniquely sloughing off lean muscle for individuals. It's the sheer magnitude of weight loss that's occurring that just inherently, it just comes with the territory. You lose weight and you lose a lot of weight. You can't just preferentially select just the fat off your sides or your thighs or your calves. Like,
so when you're so if I'm understanding, you're saying when you're in a, for lack of a better term, a severe calorie deficit,
that's exactly what it is.
Actually losing a bunch of weight, your body is going to take that weight from multiple sources, not just adipose tissue, but also from muscle.
Mm-hmm. There's all types of stuff.
Yeah. Yep. And that's just inherent with it.
Yeah. Again, it seems as though the reason that individuals want to talk about it is because, like we've mentioned, there are just really no other interventions that have had this large of an effect.
Right.
So when you start to see these results, we have the inclination to try to poke holes in it, and that's great. But at the same time, I would be hard pressed to say, or there's any good reason to believe that we should take our foot off the gas using these medications just because we're afraid that there's lean mass being lost. Because again, it does not appear when you look at the totality of this, that there's a disproportionate loss of lean tissue in people taking GLP-1 receptor agonists. There's just really no reason to believe that.
Is there any way to mitigate the loss of lean muscle mass? If you're on these drugs, you don't want to lose lean muscle mass. What can you do to reduce or mitigate that reality?
Definitely. And it's funny, you kind of got to pull from the old bodybuilding circles.
Old bodybuilding circles.
But no, it's not even really bro science at this point. It just is what it is. But a more intensive strength training program is fundamental to everybody. It's fundamental for everybody.
Yeah.
Let alone an individual losing weight at a pretty high rate. Increasing protein intake. I'm not sure if in some of these studies they had that you could look back and see what exactly the dietary intake was, or at least the macronutrient intake was.
Yeah.
But I would imagine that there's more and more of that information to come.
Sure.
But in general, increasing the amount of protein, increasing the amount of strength training is going to be integral for an individual on one of these medications, just like it is for the same reason it would be for a bodybuilder cutting for a show. Do you know what I mean?
It's that's true for just about everybody.
Right.
Whether you're on these drugs or not, you probably should be eating more protein and probably should be incorporating more weight training.
Yep. And it's just, you can't, the sheer magnitude and the sheer impact that these medications are having in terms of weight reduction.
Yeah.
There are always going to be some trade-offs. We're not saying this is a 100% clear benefit. There are issues, there are side effects, there are things. There might be a little bit, again, extra lean tissue loss because of the magnitude of weight loss.
Right.
But that doesn't mean that we just now poo-poo this completely. It's you take that with a grain of salt, and maybe we try to design some research that looks at maybe individuals who are taking these medications and in addition to intensive lifestyle therapy and such, in dietary interventions, maybe there's a more intensive strength protocol or a more intensive protein protocol, let's say. I think it's too early to write this off or anywhere close because of the lean tissue stuff.
Yeah. My favorite economist, everybody has one of those, right?
Mm-hmm.
My favorite economist likes to talk about how there are no magic answers. Everything is a trade-off. And that makes a lot of sense in this sense that this drug, it's not perfect. It has trade-offs. There's the monetary trade-off. There's the potential GI issue trade-offs. There's the loss of muscle mass trade-off. But what are you gaining in benefit? And is that trade-off worthwhile? And that, for some people, absolutely. For a lot of people, probably not. It just depends on who the person is and their specific situation.
Yeah. And I don't use the bodybuilding example to alienate, but more to analogize as to what is the crux of what's happening in somebody preparing for bodybuilding, a bodybuilding show. You want to be as lean as possible on stage, which requires some level of weight loss. But they do whatever it is, maybe with some extracurricular use.
Some extra supplements.
They do whatever it is in their power to maintain as much lean tissue as possible, knowing that they're going to certainly, amidst their preparation for the stage, that they're going to inherently lose some lean tissue. It just comes with the territory. It's just an analogy to what we're seeing in the participants of these clinical trials and in the general population.
Makes sense. It would not be fair to finish this conversation without also talking about some of the more positive headlines and exciting things that we're seeing coming out beyond just the weight loss elements of this. These drugs look like, and I think it's because you said the way they work systemically, neurologically, in addition to just the dietary element of it, these look like they have significant implications for addiction as well. Is that,
this was really interesting. I think just to go over again the basics, what do GLP-1 agonists do? We know the parts, like you said, in the GI tract, slowing gastric emptying, but the one that this would relate to would be the satiety. How do these drugs actually help you to feel full? What is that mechanism behind that stat, that fact that we throw out? And what they found is, and there's a whole lot of technical terms in here, but basically these medications act in the brain within the mesolimbic dopamine reward circuitry. So there is feedback that goes on. Dopamine is critical to life. Dopamine is what helps you to feel reward for everything from going to work to gambling to eating too much to drinking too much. All those things are just some function of the way that your body, and this is a much deeper conversation, but in its most simple form, to how your body, how your brain responds to dopamine and how the personality and the other parts of your brain interact with that. And there's genes, there are exposure, all sorts of things that affect that. So what I thought was really interesting, again, this is not referring to hard alcohol dependence. I don't mean to draw lines there, but around the clock drinking where you are physically dependent. We're talking about more alcohol abuse, alcohol cravings, binge drinking. That they definitely found that the reward aspect was decreased.
Wow.
So you've got the GLP-1 circulating, like we talked about, lasts longer in the body than normal GLP-1. It has kind of already hit the dopamine circuitry in the brain to help you to feel a little bit. It's not going to be as overtaken by the feeling of alcohol. There's some satiety in that receptor, and now the alcohol is not as desirable. You don't have as many. You don't like it as much. Some of it's anecdotal, but they looked at mice. So there's a lot of things in there, and again, it does link directly back to the one component. GLPs have a lot of benefits regarding weight loss, blood sugar control, but one of them is that increased satiety, and that's believed to be a dopamine reward circuitry.
Yeah. Right. So this is beyond, I don't want to say beyond cutting edge. This is not, nobody is prescribing these for addiction or anything like that. We're talking about, this is what seems to be on the horizon and researchers are currently looking at as potential use cases or some new form down the road.
Yes, and it does make sense. And again, for now, from the way we understand it and just the way that, dependence would work, this is more, maybe you've come off for a period of time, you're clean for a period of time, or you're looking at maybe just decreasing your abuse, your binge drinking, those kind of things, that this can step in there.
Fascinating. That's really exciting. The more we learn about the body and the systems as a whole and how they interact, the ability to help someone with something like this is really exciting. Did we leave anything out? Hopefully we cleared up some confusion there. It's all over in the headlines.
Yeah, I mean, just reading through some stuff, for as much negative or as much positive celebrity, hype, there are some celebrities that are even coming out and saying like, no, this is terrible. Especially the ones that are like, again, for those who are looking for dramatic weight loss and maybe their BMI, there's no valid reason to be on it. They're like, I did the hard work to lose, 20 pounds, or 20 pounds. And people are accusing me of being on this drug. And so like, there's equal parts of both, the hype and, people who are kind of like dispelling rumors that they're on or not on. And
I mean, it is another example of this being so close to the natty or not conversations, or the testosterone use in sports. Basically, is this person, is this athlete natural or not? They're showing these veins in their shoulder and they look a little questionable and they're performing at a really high level. We must question this. And now it's the same thing. That you mean to tell me Jane lost 30 pounds on her own? She couldn't have done that without the medication. So
I've seen those headlines too.
I mean, it is so real, and
it is everywhere.
It's wild.
It's not that you can't. This is just a tool, and the fact that people are having to have these conversations is kind of sad. That we as a culture really like to tear people down. The important thing is they lost weight. Man. They got healthier. Isn't that what we're supposed to be focusing on? Mm-hmm. Oh man,
I think it just speaks a lot to the quick fix, the microwave culture. Mm-hmm. For those who don't have these pre-existing conditions, they're not pre-diabetic or diabetic, or they have, they're suffering from obesity or, those types of things. Like, people just want that quick, that dopamine hit. Yeah. And they just want that microwave. I'll just have it now. Yeah. Even in the cases that we read, looking to shed a few pounds.
Yeah.
I it's ridiculous. I knew I didn't have to. Well, what are you doing?
Yeah.
In the development of these medications, you had to wonder, as this data was coming out, that some of the researchers were probably just like, oh my goodness.
Inevitable.
Yeah. There's going to be people, this is going to be insane.
The drug companies liked it though. Right. They were happy to have it go down that path.
Right. Like, at the same time, you wanted all the good that came with it, but then you're also sitting there like, this is like the next lifestyle PED right now.
Yeah.
Oh, wow.
Yeah. We live in a complex system, right. And it's you want to cure cancer because curing cancer is a good thing to do. Also, the person who cures cancer is going to be fabulously wealthy. Mm-hmm. So what's the reasoning? Does it matter? The important thing is we cured cancer. Well, no, we haven't.
Nice when those two things come together.
Yeah, wouldn't it be?
Sure.
All right. Well, that is all we've got for today. If you want to hear more from us, if you want to follow us, check out our website, askjoedimatteo.com. You can sign up for our newsletter there, keep you up to date on what's going on. You can subscribe to this show or past shows. You can find shows from the show that started all of this, the Ask Joe DiMatteo show, all there on our website, as well as a whole host of products. We've got all sorts of different supplements that can help you live better and longer. Those are all available on our website. If you have any questions, email us, questions@askjoedimatteo.com, or you can leave a comment. If you're watching this on video, leave a comment down below, give it a thumbs up, 5-star rating, but put your questions down there and we'll try to answer them. We try to respond to every single one. We want to hear from you guys. Show notes, any of the articles we referenced, all of those will be available down below. Go check them out, read for yourselves. And if you learned anything from this episode, please pass it on, share it with other people. This information has got to get out. We've got to clear up some of these misunderstandings on both sides of this conversation so that more people can get the help they need and avoid trouble that they don't need to be getting into. All right. Big thanks, Josiah Schweinberg, our engineer, Michael Depesh, our editor, Joyce Gibb, the nurse practitioner who handles private consultations, Diane Silverman, who manages our product, Terry does scheduling, Cecilia does distribution. That's Dante DiMatteo. That's Joey DiMatteo. I'm Tyler Andrews. Thanks so much. We'll see you guys soon.